Despite historic gains in treatment, prevention, and access, HIV/AIDS remains a grave threat to the world's most at-risk key populations. HIV/AIDS has become a pandemic of the most marginalized, most disenfranchised, most vulnerable, and most difficult to reach. For these populations, the epidemic is hardly contained. Progress is painfully slow, and the risk of regression never fades. Over the course of 2019, we traveled to 3 HIV/AIDS global hotspots to see why the pandemic still holds a tenacious grip in an age of transformative scientific breakthroughs.
Some guys, they come in, then they want to rape us. So the workplace is not safe for us.
Here in Soweto, South Africa, these young women are sex workers in a township tavern which has become their home. There is high HIV prevalence and low treatment coverage in this large burgeoning population. There has been some progress in providing treatment, but not nearly enough to stop widespread transmission. The women told us they have been frequently assaulted, some have been pepper sprayed, and all have been raped. Because of their marginalized status, there are few protections. Police responsible for protecting them often are their predators.
Whenever they see you, it's like a sex worker is nobody.
They treat you like you are a useless person.
We are trash.
Just a car drive away, we met other sex workers whose plight was even worse. Soldiers from a nearby military base had burned these women out of their makeshift shelter. Their HIV medicine was destroyed in the process. They made a new home under a fallen tree. They told us that some of the soldiers have continued to purchase sex from them.
None of those women today told you that it was their first prize. They did not say, this is my job. I got to grade 1 and the teacher said, what do you want to do? And the boy next to me said, I want to be a doctor. And the girl next to me said, I want to drive a fire engine. And I said, I want to be a sex worker. No one said that.
Jenny Pfeiffer-Coutier runs a support service for sex workers in Soweto, providing healthcare, counseling, and protection. She estimates that between 7,000 and 14,000 women sell sex in the township.
They're there because of circumstance. They're there because we have an economy that's failing. They're there because we have an educational system that has failed our children. They're there because of the legacy of apartheid in our country. They're there because of patriarchal norms. They're there because they've been brought up to believe that they are just bodies to be fucked, and they're not. They are so much more than that.
These sex workers, whose plight is so extreme, capture the larger realities fueling the pandemic in South Africa, where some 4,500 citizens are infected each week.
If you take the survey data in South Africa, the overall prevalence of infection is about 30%. There are 12 districts in this country where the prevalence is in excess of 40%. And if you go into these communities and, for example, do a survey amongst pregnant women, by age 16, for example, 1 in 10 could be infected with HIV. By age 20, it's 1 in 3. By age 25, it's 1 in 2. And in fact, by the time you get to age 30, 60% of men and women are infected with HIV. So this hyper-endemic epidemic settings give you some indication that despite an incredibly unprecedented high prevalence of HIV infection, you're continuing to see high rates of new infections taking place, and that these numbers give you some indication of the order of magnitude of the problem.
Tobekile Mafamulo is mayor of Pietermaritzburg, which has one of the highest HIV prevalence rates in the country, indeed the world. She says adolescent girls and young women, who make up a third of new infections, arrive from rural communities in search of jobs and education. They seldom succeed, but they do find something else which puts them at risk.
So when they arrived here, they find the sugar daddies. Those sugar daddies promise them money, and they slip around without preventing themselves.
There are two key characteristics that drive the high rates in young women. The first is their choice of who they have sex with. The older partner, by about 10 years on average, carries the highest risk for them. So it's this age disparity in their partnering. And the second is that young women have a certain kind of vaginal milieu that we call genital inflammation. These are immune cells that infiltrate into the vagina, and they increase women's risk of getting HIV. So there's behavior and there's biology, and they combine in this almost the perfect storm.
Despite progress in containing HIV/AIDS in South Africa, many conclude progress has stalled.
We're still talking about women and girls as being hyper-exposed to risk of HIV infection, but we've been using that language for a decade. That's what's frustrating, is we shouldn't still be talking about this, because we should have talked about it, gathered the evidence, recognize what the problem was, and then see what we can do to deal with it. And that's why I feel we're in a very precarious position. We have to find the political will, we have to galvanize society, we have to get those other 3 million people onto treatment.
AIDS activist Mark Haywood and other experts argue the country's healthcare system itself compounds South Africa's extraordinarily high HIV/AIDS prevalence.
There is an overburdened and crumbling health system, and a very unequal health system in South Africa. There's two health systems. There's a private healthcare system, which caters for 17% of the population, the top 17% in terms of income and wealth. And then there's a public system that deals with 83%. They spend the same amount of money, each system, each year, but one amount of money goes to 17% and the other goes to 83%. Because HIV in our country is largely a disease of poverty, or is driven by conditions of poverty, the burden of HIV falls on the public sector. I would say, there isn't a figure for this, but I would say probably 95% of the burden of care, of the burden of treatment, of the burden of treating people with opportunistic infections falls on the public sector, health sector. So again, if your public health sector is weak and weakening, then that heavy burden will further collapse it.
So we're punch drunk. We have a quadruple burden of disease. We're punch drunk, we are running out of money. We're in this protracted, stagnated space. Normally in our situation, countries have communicable disease in epidemics, and then as they transition to middle and high income countries, the communicable diseases go away and you have non-communicable diseases that you can then focus on. In South Africa, we're kind of stuck with everything and we're running out of money to manage anything. And so what we're seeing is a health system that's breaking. We're seeing our maternity and child health gains stagnating or reversing. We see our inability to manage hypertension, diabetes, our inability to diagnose and put people on TB treatment, and an HIV epidemic that is out of control still in South Africa.
South Africa remains hugely challenging and hugely important to U.S. security and humanitarian interests. It remains the epicenter of the global pandemic. Millions remain untested and untreated. Young women and adolescent girls stand at the very center of the pandemic, vulnerable to the virus and to abuse. And now South Africa is beset by a coronavirus pandemic that threatens to wipe out the historic gains in HIV of the past 2 decades. There's too much at stake for the United States to turn away from these challenges.
Here in Odessa, Ukraine, providers exchange needles for intravenous drug users living at a tuberculosis sanatorium. Their group, The Way Home, provides needles, testing, and other services to key populations in the port city wherever they may be. Back when the group started in 1996, 60% of Odessa's intravenous drug users were HIV positive. Today, it's down to 20%. Bringing that number to zero is still a long way off. Natalia Kitsenko, Deputy Director of Way Home, said that stigma and cultural aversion are consistent barriers to reaching these most at-risk members of society.
Было ли какое-то сопротивление вот от других жителей? Нет.
Было, оно и сегодня есть. Первые наши, вот в те годы, в 96-й год, наши выезды очень агрессивно принимались населением, потому что население боится людей, употребляющих наркотики, потому что это связано с мнением о них, что это только криминальная среда. Вот. И даже 2 года назад нам забетонировали вход в наш бывший комьюнити, который находился на проспекте Шевченко, потому что жители были против.
Stigma was the topic of the day when we visited an intravenous drug user support group. The group's leader explained that stigma often comes from those who are supposed to help.
Это касается, как я пришла с ногами, вы знаете все наши проблемы с ногами, пришла к хирургу, когда воспалились ноги. И он так прислонился к стене, так, повернись, ой, подними штанину, там сделай что-то. И это было настолько неприятно. Не то, что не одел перчатки, не подошел ко мне, а он просто, мне кажется, что он надел 3 пары перчаток и вжался в стену, чтобы я только не кашлянула в его сторону, потому что он сразу подцепит ВИЧ. И он самое тяжелое его форме. Как-то так. Но это было ужасно. Мне не хотелось ничего. Мне хотелось скорее выйти из этого кабинета и все. К сожалению, они нас вот так вот обламывают.
Rejection by healthcare workers is a significant hurdle in Ukraine, where the country is moving away from clinic-based support services towards treatment by individual doctors. Although vilification persists for key populations in Ukraine, unlike neighboring Russia, it has strong NGO involvement and laws protecting the most vulnerable. Ukraine is far ahead of its neighbor to the east in containing HIV/AIDS. Early on, a vibrant independent sector emerged with support from the Global Fund and PEPFAR, which achieved significant improvements in prevalence rates and access to care. By contrast, Russian President Vladimir Putin has systematically targeted key populations and kept out NGOs as Russia's prevalence rate has become the highest in Europe.
Whereas most other places in the world, we've seen progress forward in terms of a more humane, a more progressive, enlightened attitude toward many of the key risk groups. In Russia, we've seen at best stagnation in that area and in reality a backsliding over the last decade.
This has caused alarm in the global health community.
We're exercised about the threat of HIV in Russia because it's one of the few places in the world where the threat continues to grow. In the last decade, this part of the world and the region, the number of new cases has gone up by about 30% annually. Russia's driving about 80% of that. So we're concerned about the continued growth. We're concerned about what we don't know.
It's the largest epidemic in Europe, and that's not only because it's the the most populated country of Europe. It's the country of Europe, of the WHO European region, with the largest prevalence and the largest incidence. It's a country and a region where HIV/AIDS is still expanding. And that's the exception in the world. It's an epidemic that is out of control, or I would say that is certainly far from being controlled. It's an epidemic that is still concentrated among vulnerable populations, despite the official discourse, which is now heterosexual infections have taken the lead over, let's say, people who use drugs. It's clearly an epidemic that is still among vulnerable groups and their sexual partners.
So many of the key populations have incentives to remain hidden, to remain outside official data collection. And so the question marks, coupled with what we know about the expansion in risk groups and a government policy that mitigates against harm reduction, mitigates against prevention, mitigates against control of the epidemic, leaves us wondering how they're going to move forward in that part of the world.
Russia and Ukraine's armed conflict, stoked by Russia's direct interventions, has destabilized Ukraine's HIV/AIDS progress. Luhansk, Donetsk, and Crimea have been outside of Ukraine's control since 2014. Much of the information on key at-risk populations in the areas comes only from word of mouth. We met Artyom, a gay man living in Odessa, after he managed to escape Donetsk. He described what life was like there under occupation.
Я и не был в безопасности. Когда был клич по референдуму, кучка непонятной толпы била все направо-налево, что не было согласно с ним. И когда ты еще плюс в этом моменте еще открытый гей, ты вдвойне опаснее.
Artyom explained that some in his community were punished or killed just because they were gay.
Есть те, у кого наоборот родители предавали. И просто-напросто отправляли тебя либо окопы рыть, либо расстрел.
There were reports of Russian military targeting another group, intravenous drug users.
It was very, very tragic and harmful situation, especially with cutting off methadone programs. It was like in Middle Ages, so police or special service came and they actually burned the medicines in a fire, like in Middle Ages books were burned, as evil or whatever. And it was so dramatic for the patients because in half a year time after this situation in May 2014, actually over 80 patients out of 800, about 10% died. Some from health complications, some committed suicide because some went to illegal drug use, street drug use, and also died from overdose because they used to be on medical treatment.
Aid is currently delivered via two channels, UNICEF and the International Red Cross. Getting exact figures on the scope of the epidemic in these contested regions remains elusive.
Но в любом случае это серая зона. А ее серость заключается в том, что все данные под вопросом, количество людей всегда находится под вопросом, и это когда ты наугад в темноте делаешь попытку помогать, но в любом случае это надо делать. А на самом деле это все-таки явление, у которого нет опыта в мире, когда при войне надо реализовывать какие-то гуманитарные программы в области СПИДа. И нам пришлось учиться на ходу. Потому что нам пришлось работать с неподтвержденными данными, с людьми, которых сложно найти. А все-таки там 12 тысяч людей, которые принимают терапию. И каждый день некоторые из них перемещаются туда-сюда, обратно. Большое количество людей перемещается туда-обратно. На сегодняшний день мы уже стабилизировали программы помощи туда. Это программы лечения, которые мы туда поставляем. И программы ухода и поддержки, которые финансирует глобальный фонд.
Back in Odessa, Ukraine, Natalia Kitsenko and her colleagues assist internally displaced Ukrainians from the conflict, trying to mitigate the HIV/AIDS epidemic in Eastern Europe the best they can.
PEPFAR and the Global Fund, with their partners in Ukraine, have achieved substantial success, but that success remains fragile, particularly in reaching the most marginalized and dispossessed. The outstanding question today is, as the Biden administration renews its links with its allies, as it revisits Russia and Ukraine, as the coronavirus advances, how will HIV figure in U.S. geopolitical calculations? HIV should not be overlooked. It should be a key component element of our engagement with both Russia and Ukraine, with a special focus on key populations. The United States should continue to support Ukraine in its public health versus punitive approach towards HIV. Russia continues to make wrong choices and to separate itself from the rest of the world in HIV. That is dangerous to Russians, it's dangerous to the region, it's dangerous to global HIV/AIDS efforts. The United States should continue to speak out and to seek incentives to change Russian behavior, and it should do everything it possibly can to support those within Russia who continue to provide services desperately needed.
I was in a monogamous relationship and I was 20 years old and I contracted HIV.
DeMarcus Jones is just one of several thousand gay men living with HIV in America's South. The region has become the epidemic's new front line in the United States. According to the Centers for Disease Control and Prevention, the region was responsible for more than half of the country's new infections in 2017. Unlike South Africa or Ukraine, this persistent crisis is in the United States' backyard, ignored for years. Fueling the epidemic in the South are poverty, racism, stigma, cultural norms, and a lack of health literacy and education. Jones, an HIV youth outreach assistant, and his friends talked to us at a center for LGBTQ youth in Memphis, Tennessee.
Education for me, especially Memphis, poses a problem because our schools follow an abstinence-based program.
The issue is not restricted to Memphis. Abstinence only dominates education in the South.
The biggest thing as to why there's really no real education in school about sex is, we live in the Bible Belt. We know that religion plays a huge part in pretty much every aspect of everyday life in the South.
The Reverend Darnell Gooch, a pastor of a Memphis congregation that serves the LGBTQ community, agrees.
I pastor individuals even today that some of them still think that they're going to hell. In other church settings, they have been ostracized, they have been marginalized, disenfranchised, dehumanized, rejected. They have been kicked out of churches. They have been told that they could not serve in leadership positions or sing in the choir or even be open, even as it relates to who they are as walking in their truth.
And I think the Black church is a huge reason as to why there is a stigma around HIV. Because of course, in the Black community, the church is, that's where people go for everything dealing with their problems a lot of the times. And if they can't go to them and talk about it, then they're not going to talk about it. And then you not talking about it leads to you not getting tested. You're not noticing symptoms that you may be having. You're not wanting to talk about those things. And then that leads to you not only contracting HIV or something else, but the Black church doesn't, the Black church just unfortunately doesn't welcome that topic in the church a lot of the times. And when they do, it's a lot of judgment.
Jones and others say that many LGBTQ youth who'd come out to their families often face immediate ostracization and financial hardship, which often leads to risky behavior.
I've seen kids get kicked out of homes. I've seen kids get cut completely off. And then even the extreme cases where those individuals were trans-identifying individuals, like a lot of our shelters and stuff here in Memphis are very strict on how you present and how you identify that you can't even get a bed at night sometimes. So a lot of our youth here, we do this thing called couch surfing, where they literally go from house to house just crashing on whoever's couch that'll have them for the night. And me personally, I just don't feel like that's a way to live.
It's heavy in every area and aspect of our lives as a transgender woman of color, from your family accepting you to you finding employment, housing, love, healthcare. Every aspect that you could possibly think of, it's a struggle. And when you've dealt with trauma, we tend to do things that we wouldn't if we hadn't. So may it be destructive behavior and drugs or unprotected sex, all of those things with the combination of a lack of education or knowledge in HIV and AIDS, the homelessness, the lack of education, the lack of employment, the family not being supportive, so you're put on the street. It equals to being positive.
Memphis has the 8th highest rate of infection in the United States. But many new infections in the South are coming from rural and suburban communities. Across the river, in rural West Memphis, Arkansas, providers and advocates without the benefit of an LGBTQ community center or church struggle to meet the marginalized.
The stigma is real here in this county, most definitely in the county as well as the southern region. We are still afraid to talk about HIV. We're still afraid to talk about just STDs in general, but it's here and we need to deal with it.
In the South, there's certain challenges, I think, particularly in rural, with, of course, the lack of access, the health literacy, the housing, the stigma, which I think is a big kind of issue that we deal with even sometimes, even in this facility, treating the population.
Dr. Susan Ward-Jones is Chief Executive Officer of the East Arkansas Family Health Center, which treats and counsels those living with HIV/AIDS. She believes the efforts to contain the disease are hampered by the local population's denial of the realities of HIV/AIDS in its community.
I think that's a big hurdle because people don't want to know, people don't think that this will hit home or that they're not affected by it. So I don't need to know about that, and anything dealing with sex, I mean, that's always a big issue. If people were educated more, I think that, we would do much better with this disease, sex in general, but, it's just kind of not talked about.
To make the needed commitment to eliminate the HIV epidemic in the United States within 10 years. We have made incredible strides. Incredible.
Surprisingly, the Trump administration launched an ambitious plan in 2019 to end the HIV/AIDS epidemic in the United States by 2030.
Well, the epidemic in the United States is one of great disparity. This is not a generalized epidemic. It is very disproportionately weighted towards African American men who have sex with men and Latino men who have sex with men, with transgender, and to some extent to injection drug users. It is both demographically, as per the situation with African American and Latinos, as well as geographically focused. That's the bad news and the good news. The good news is that you know what the focus is and you can concentrate on it. In the United States, if you look at the map of the United States, it's broken up into these little boxes that are counties. There are 3,007 counties in the United States. 50% of all of the new infections are contained in 48 of those counties, plus Washington, D.C., plus Puerto Rico.
Titled Ending the HIV Epidemic, or EHE, the initiative aims to reduce the number of new infections by 75% in 5 years, and at least 90% within 10 years. The plan focuses primarily on the 48 counties, Washington, D.C., and San Juan, Puerto Rico, which are the geographic hotspots of new infections. Most are in the South. The initiative uses federal dollars given to local stakeholders who craft individualized plans for their communities. CDC Director Robert Redfield and others went on a nationwide tour to visit these communities and said he learned some lessons about the epidemic.
The challenges that I've seen in my trips are several. One is stigma's still there. And you've heard me say before, stigma has no place in public health. It's the enemy of public health. But the reality, it's still there. Some of that stigma is external, but some of that stigma still is internal. People who have self-stigmatized themselves. We got to get through that. But the other area that I didn't appreciate before I went out and saw the different jurisdictions is there are certain social determinants of health that are really going to be a problem in certain jurisdictions, and most notably homelessness. Housing is a medical issue. I think I didn't appreciate that probably before I had the opportunity to visit these jurisdictions, but housing is a medical issue and homelessness is a public health issue.
It's curious that the Trump administration chose to pursue an aggressive plan concentrated in the South to tackle the HIV epidemic among Black and Hispanic gay men, poor women, and transgender individuals. Why? It emerged out of the determined effort of Dr. Anthony Fauci, Dr. Robert Redfield, and others, individuals who've been working for decades on HIV. The plan is credible and compelling, it's doable, it's affordable. It marks a significant turning point. Progress has been stalled. COVID-19 put the plan on hold. The plan ran headlong into the Trump administration's anti-gay bias, the lack of long-term sustainable funding, the attacks upon the Affordable Care Act, and the deep distrust among these communities. But the plan itself remains compelling and viable. There's every reason to be hopeful that the Biden administration will pick up the thread with bipartisan support. Dr. Anthony Fauci now serves as the chief medical advisor to President Biden. The Biden administration has made known its deep commitment to ending disparities based on race, gender identity, and poverty. It's made known its commitment to outreach and engagement and investment in these marginalized communities. Ultimately, that is the solution to HIV in America.